Hello once again, guys. All right, so we're going to go back through the last portion of this chapter. We're going to be talking about shock, basically. Hemorrhagic shock is what we're looking at, bleed control. And here is the cycle of hemorrhage shock. Basically, the trauma that happens, loss of blood, decrease in delivery of oxygen throughout, baroreceptor triggers, hormone release to the nervous system, heart rate and contractility increase, vessel constriction happens, respiratory rate increases as the body's opportunity to start taking over and starting to control what's actually happening during that shock process, trying to do its job. Patient exhibits tachycardia, weak peripheral pulses. Things are starting downward spiral, getting worse. Volume loss continues to overwhelm the body overall. The brain becomes ischemic and fails, causing a severe drop in pressures. So we're lacking blood flow to the brain, confusion is setting in, all this kind of stuff. Patient becomes unresponsive. We're hitting the irreversible spot in shock. That's where the brain started breakdown, and now we've hit unresponsive, dramatic drop in vitals, further decrease in blood volume, perfusion, and blood pressure leads to brain tissue death, multi-organ failure, and eventually patient death. So the whole cycle in which it happens, the initial beginning, moving all the way through. And so our job, so you understand, is to recognize up in here, we've got this problem. If we can recognize in here that we've got this problem, we can stop the rest of the cycle from happening, or at least put some major brakes on. If we don't catch it here, we start to move into this area here, we're on the downward slide and we're fighting an uphill battle. Once we get here, there's possibility we show up on scene where we're into this area here. We do all we can, knowing that the chances of them surviving are slim to none. And if they do survive, more than likely they're going to end up dying later on in life, as it is. So this is the cycle of hemorrhagic shock. Based approach, evaluate scene safety and mechanism of injury. We understand this. We need to make sure keeping the scene safe. How did this actually happen? Assess the mental status, ABCs, ABPU, the four questions if possible, airway, breathing, circulation, and that's our ABCs. Assist breathing, administer oxygen as needed. For unstable patients, perform a rapid secondary assessment, obtain baseline vital signs, loss of 15% or greater or less than 50% of blood volume will cause changes in vital signs. Greater than 50%, greater than 15% of volume will change the overall vital signs. You'll start to see the increase in pulses, increase in respiratory, and the blood pressure maintaining at the start, and then it's going to start to drop at that. Mental status, the things we're looking for here, we're looking for restlessness, anxiety, and altered mental status, where there's confusion and they can't answer those four questions properly. Peripheral perfusion, pale, cool, clammy skins, weak, thready, or absent peripheral pulses, and delayed cap refill, delayed being greater than 3 seconds in most patients. Vital signs: increased pulse rate, weak, thready pulse, increased breathing rate, deep and shallow, labored or irregular breathing, narrow pulse pressures, and decreased blood pressure overall as well. Other signs and symptoms: dilated pupils. As your body starts to pull blood away from peripherally, the nervous system becomes affected, and we kind of widen out, we slow down, we relax, and everything opens up in our body. Thirst sets in. People become very thirsty. Remember, we're not giving anything in this case, but that's a sign we're looking for. Nausea, vomiting, thirst, adding water to them or any kind of fluids is going to increase that nausea, vomiting, causing airway issues. Pallor or pale. Cyanosis of the lips, blue colors in the lips. You're seeing the ashen color. I've watched people bleed out and watch the color drain from them. They turn that pale color. But cyanosis in the lips and fingernail beds are something we'll identify pretty quickly. Use standard precautions always: gloves, goggles, face mask if needed. Maintain an open airway. Administer oxygen and assist ventilation as needed with a bag valve mask. Control external bleeding. This is direct pressure, pressure bandages if needed, and then tourniquet if it's the worst case scenario. PSAG. I'm going to talk about that in a little bit. It's at the last portion of the slide. It was taken away from us just like tourniquets years and years and years ago. It still is now in effect back in use. You won't see it very often, but I think it's important that you know what it is, and I'll show you some slides of what it actually is. Place the patient supine, flat on their back, splint bones or joint injuries, and keep the patient warm and transport immediately. Real quick, let's talk about this. I've got a trauma. I've got one broken arm. Okay, by splinting, we actually can control bleeding internally by putting a splint on. That doesn't mean it's going to stop it, but it's going to control it. So we take care of that one. But here's the issue: if I've got a patient that actually has, um, multiple long bone fractures, both arms, both legs, okay, upper and lower portions of both, fractures in all of these. I am not going to take my time to splint these bones and joints one by one. I'm going to use the backboard to splint the entire body, okay, if that makes sense. Basically, we take the person from the site that they're at and we put them onto the backboard and we actually use that as splinting injuries. Pneumatic shock, this is the PSAG we're discussing. Controversial device used in some cases for hemorrhagic shock. Again, it was something that we saw, we knew how to use. It never really showed up, but they still have them out there, and they actually serve a purpose. What they do is they can inflate, squeezing the lower portion of the body, pushing all the blood, aiding the body and pulling blood out of those lower portions and back to where it's important to have it. But there's some things we need to understand about that before we actually put it into play. Here is your PSAG and what it actually looks like. Anti-shock garment, PSAG. So these are obviously the legs. A big sign, please do not cut, because this is an expensive device. It looks kind of crazy, space age kind of stuff, but it's really a simple thing. Basically, it unfolds completely. You see the Velcro straps on both legs and across the lower abdomen. Unvelcro everything. You basically roll the patient, slide them over the top, then you roll the legs and Velcro the legs back on and Velcro the abdomen. This foot pump, you've got a petcock valve that actually allows you to inflate on either side. In this case, we're going to open up both and we're going to allow air to inflate here. So what happens is, got a patient, low blood pressure because of external bleeding. And let's say this would work out perfect. We've got a massive femoral artery injury where he's bleeding out externally, and we really can't control this. If we could get this on quickly by placing some 4x4 gauze pad underneath this PSAG, wrap it on, begin to pump it up. Not only is it creating pressure over that injury, but it's also squeezing from the ankles back up, pushing all the blood out of this portion of the body, now controlling that bleed as well. If the vitals are low enough, we then can change this petcock valve, shut this off to where we have air just coming in here, which goes to the upper or lower torso, the abdominal area. Again, we're pushing pressure in, squeezing that abdomen, pushing blood back up into the heart, lungs, and brain. It actually, if you know how to use it right, it can be deployed very quickly and work really, really well. But there's some caveats to this. It can't be used on a patient who has head injury because we're pushing pressure to the head. It can't be used on patients that have chest trauma, pushing blood to the chest, or who have uh, respiratory distress issues, say flooding the lungs, basically CHF, congestive heart failure. Because again, we're filling up the portion of the body that's already flooded with fluids and we're adding more to it. And again, spinal injuries could be another reason we wouldn't use this, because we've got to roll this person to get them on. It's probably the best idea. It is a great device that can slow the process of shock. It is not going to stop it, but it can slow it, control it, if we know how to use it right. PSAG indications: suspected pelvic fractures with blood pressure of less than systolic blood pressure less than 90 degrees, 90 on blood pressure. Suspected interperipheral hemorrhage with hypertension. Hypotension, low blood pressure, suspected retroperitoneal hemorrhage with hypotension. So these are some of the reasons we would use these. We actually got fractures of the pelvis, hypotension from either intraperipheral in the abdomen or retroperipheral in the kidney area, basically. Penetrating thoracic traumas, contraindications. We cannot put this around the abdomen because we've got penetrating trauma. Splinting of lower extremity fractures. If there's a fracture, we can't put it on. Eviscerated abdominal organs, another reason we can't put this on. Impaled object into the abdomen, can't do it. Pregnancy, can't do it. Cardiopulmonary arrest, can't do it. Congestive heart failure, as I was talking about, can't do it. Pulmonary edema, filling of fluids in the lungs, can't use this. Do not deflate PSAG once it has been, do not deflate the PSAG once it's been inflated, unless ordered to do so by medical direction. Contact medical direction about deflation if you suspect ruptured diaphragm, the patient's experiencing respiratory distress after inflation. So there are some precursor kind of things that we can identify that tell us, hey, we may need to take this off. Once it's on, though, it should stay in place until a doctor. And then, so we're looking at the skills here. As you can see, you're using a backboard because it's a pretty traumatic injury, probably, or we got spinal injury possibly going on here. You start putting it on the abdomen, now working down toward the legs. Most important is when we pump, we're pumping the lower portions first, up to the upper portions, up to the abdomen, and then we're keeping a good track of the blood pressure throughout this process as well. Check this out. The gauge is on backwards today, working right. Whatever, just kidding. Okay, that's it, guys. Thank you very much. I think we're done with chapter 28 as far as lectures are concerned. And I'm going to keep posting up a few other things for us to work on. Remember, all things are due on Friday. We will have our test coming up on Thursday at 6 o'clock. We'll run just like we run it. Okay. Thanks, guys. Take it easy. Bye.